The views expressed on the following program are designed to amplify those of the speaker and not necessarily those of KAAM, DJRD Broadcasting, or its sponsors.
It is time to Ask the Pros, the only live local interactive radio program that addresses home, health, and wealth matters Monday through Friday. A program hosted by arguably the most knowledgeable and reputable authorities in their respective industries, affording you the rare opportunity to ask them any questions related to their field of expertise for free. Just pick up the phone and call KAAM right now to Ask the Pro. Now, here's Dr. Birnbaum.
Good afternoon, everybody. This is Dr. Dennis Birnbaum. I am an internal medicine doctor with a subspecialty in hematology oncology, formerly at the University of Texas, MD Anderson Hospital and Tumor Institute. And this today is Cancer Update, a short walk through a long journey. The phone number here at KAAM 770 AM on your dial is local number is 972-445 0770, and the toll-free number is 877-272-5226. I'm proud to say today we are going to have a discussion on pain management. A representative from the Dallas Pain Clinic, Dr. Hubert Fu, F.U. Dr. Fu graduated from the University of Oklahoma Health Science Center, did his internal medicine training at Methodist Medical Center here in Dallas, and then did a follow-up residency in both anesthesiology and pain management at the University of Texas Southwestern Medical Center here in Dallas. He is a diplomat as of April of 2006, and he is a member with Dr. Sanjay Isaac of the Dallas Pain Clinic. The phone number at the Dallas Pain Clinic, as you will definitely want to give them a call, because we're going to talk about pain in both cancer patients and non-cancer patients, is 214-471-5975. Let me repeat that. That's 214-471-5975. Last week we had the pleasure of speaking with Mr. Anthony Flores of Hospice Plus. Some people have called us asking for us to repeat their phone number. Mr. Flores' phone number is 214-534-7572. He is one of the top representatives for Hospice Plus in dealing with patients, both cancer and non-cancer patients, Alzheimer's patients, dementia patients that need to be placed in hospice. The phone number for Hospice Plus is 214-343-7900. I'd like to address a couple other things before we speak with Dr. Fu. A lot of patients go through chemotherapy, even radiation therapy, and they complain that their eyesight has changed dramatically, that they don't see as well. A lot of things are never explained to them, that chemotherapy as well as immunotherapy, drugs like Avastin, cetuximab, Tarceva, as well as systemic chemotherapy can affect your eyesight. I happen to know a group at Eyepieces, which is located at Legacy in the Tollway. They are proficient at dealing with cancer patients. The phone number there is 972-661-2020. It's called Eyepieces. They deal with cancer patients. It's located at the end of the tollway at Legacy. If you're going north, you take a right on Legacy. The first stoplight, you take a right, and it'll be on your left-hand side. That's eye examinations for cancer patients on chemotherapy. The phone number is 972-661-2020. I'd like to talk before Dr. Fu calls in about two issues. Number one is food to the rescue. We have seen over time to help fight inflammation, to help fight cancer, in dealing with the problems while you're on chemotherapy. You should stock your refrigerator with colorful fruits and vegetables, many of which are powerhouses of vitamin C and beta carotene. There are two types of antioxidants that block scavenger or scoop up free radicals that damage the cells. They work in the aging heart and in cancer patients. Some of those are just general produce. In dealing with that, we look up, you don't know what the optimal dose is of colorful fruits or vegetables. And looking at Dr. Winston Craig, from the chairman and professor of nutrition at Andrews University in Michigan, they do know that phytochemical-rich fruits and vegetables you eat, the more you boost your body defenses against diseases. The phytochemicals usually are vitamins, minerals, proteins, and other nutrients. There is no shortcut in this. These include the blackberries and the various fruits. There are healthy fats. To correct the typical American's imbalance between omega-3 and omega-6 fatty acids, the aim is to get one or more omega-3 rich foods into your daily diet. Then you should consider to supplement that with salmon, sardines, walnuts, flax seeds, are foods that are fortified with sustainable algae-based omega-3. DHA are a type of omega-3 fat, such as silk soy milk with DHA. The National Center for Complementary and Alternative Medicine, part of the National Institute of Health, calls the evidence from clinical trials for the use of fish oil in easing rheumatic arthritis very encouraging, easing the tenderness in joints and stiffness experienced in the morning. They talk about whole grains. Replace white flour pasta with whole wheat varieties and cook it. Al dente, slightly undercooked pasta is digested slowly, causing a gentle rise in blood sugar instead of a spike associated with inflammation that comes from sugar, refined grains, as with white bread and processed food made with white flour. Turmeric and ginger. Whenever you eat, add one or both of these spices, which are potent antioxidant, to whatever you're eating. Turmeric, a key ingredient in Indian curry dishes, reduces inflammation by lowering levels of the 4 inflammatory enzymes. The next is your legumes. The beans are your best friends. Black beans, pinto beans, lima beans, you name it. They are all soy products. Though there's no guideline for how much soy we need daily, a good estimate is 1 to 2 servings daily, or the equivalent of 25 grams of soy protein, which has shown good results for lowering heart disease and lowering the risk of cancer. You'll get the most benefit from eating whole soy foods, edamame, which have all the nutrients, fiber, and phytochemicals, in addition to types of phytonutrients rather than pills or protein bars. And last is green tea. Another antioxidant powerhouse. Green tea has been found in numerous studies, including one from the USDA, to lower tissue inflammation, while other research shows that it may help with painful inflammatory skin changes such as psoriasis and inflammatory changes from radiation therapy. So keep all of this in mind. Your nutritional support is very important. We're going to talk in a moment with Dr. Herbert Few, FU, from the Dallas Pain Clinic. His phone number at the Dallas Pain Clinic is 214-471-5975. He is an associate of Dr. Sanjay Isaac, and we're going to talk to him about pain. And one of the most recent interesting things that I got was, why is pain undertreated? And this is a simple question with multiple answers. And there are basically 5 reasons, they say, why pain is undertreated. Number 1, doctors don't know how to deal with difficult to treat pain and sometimes don't take the time to do so. Doctors are so undertrained in treating chronic pain. They just haven't done as well in quality of life as we have in quantity of life. Most medical students receive no more than a few hours of pain training during their studies. One survey by Johns Hopkins researchers found that only 3 of 126 U.S. medical schools require courses, while 33 schools have required classes that contain sessions on an average of just 5 dealing with this topic. Having said that, we are going to introduce you to Dr. Hubert Fu. Dr. Fu?
Yes, sir. How are you doing today?
I'm fine, thank you. How are you? This is our KAAM audience. This is Dr. Herbert Fu, graduated University of Oklahoma Health Science Center, trained at Methodist Medical Center right here in Dallas, and did his residency in anesthesiology and pain management at the University of Texas Southwestern Medical School. He's a member of the Dallas Pain Clinic, along with Dr. Sanjay Isaac. The phone number of this clinic is 214-471-5975. And any audience that wants to call in and ask Dr. Fu a question here at KAAM, the number here to call in is 972-445-0770. I noticed, Dr. Fu, under your proficiencies is in cardiovascular anesthesia, neural anesthesia, major vascular cases, and obviously in pain management. Do you deal in pain management in both cancer and non-cancer cases?
Those proficiencies came from a very thorough residency training background. I'm very well-grounded in just about everything. But I deal with the anesthetic side of all of those sorts of cases, or have in the past, both cancer and non-cancer when you're talking about pain.
In your experience, I know in the many years I've been doing oncology, and while I was also at MD Anderson, the biggest problem we had was the idea that, it's in this number 2 suggestion, that the second reason why doctors are fearful of dealing in pain is that the patient and the doctor are afraid that you will make the patient become addicted to oral medications. Have you found in your experience in dealing with nerve blocks or rhizotomies or different types of procedures that you're able to eliminate or reduce the amount of oral medication these patients are on?
That largely depends on the patient. Pain is a very, very complex syndrome. It's very subjective, so it's very difficult. There is no instrument that tells me how much pain the patient is in except for what they tell me. And they can have physical factors behind their pain. They could have anxiety factors, psychological factors. The blocks and such are very good at dealing with the physical factors, but the psychosocial factors are a little bit more difficult to ascertain where you are. So we're pretty good at fixing the physical. It's really hard to fix the other factors. We can help.
When you talk about the physical factors, are you talking about like metastatic disease to the spine, cervical, thoracic, or lumbar spine in doing nerve blocks? Do you do it by injection, or do you proceed with either a neurosurgeon or orthopedic surgeon doing a vertebroplasty or a decompressive surgery technique?
Well, it's all of the above are in the armamentarium. I mean, obviously, the earliest steps are to, for a normal pain patient is to have non-steroidals and rest and physical therapy. If that doesn't cut it, then you move them up to an interventional pain specialist who can do the injections and blocks that you were talking about. If that's not working, and there's a MRI-proven lesion of some sort where they can see like compression on the nerve roots that can be fixed with neurosurgical intervention, then a surgical intervention might be considered and warranted.
Let me ask you, in some of the experience that I have, obviously, is post-op patients with either colorectal cancer or some form of intra-abdominal procedure, and these people are always in some form of pain. How common is it, be it a neurosurgeon or somebody in your field, that would do a splanchnic or a sympathetic nerve block?
Those can be very, very useful. I mean, I'm not familiar with too many neurosurgeons intervening on that, but the pain doctors will classically go in there and try to figure out, if it's a patient who has somewhat shortened life expectancy, then they might try a block where they'll do a preliminary block to see whether the nerve that they suspect is causing pain is actually the culprit. And if that's the case, they might actually put in a block that permanently deadens the nerve to get rid of the pain to improve the quality of life for the rest of their life expectancy.
In your experience in dealing with pain management at the Dallas Pain Clinic, let me tell the audience, the Dallas Pain Clinic is 214-471-5975. If the audience is interested in going further and getting more information on this, in your experience in dealing with pain management, is the majority of your patients non-cancerous patients, either orthopedic or neurosurgical patients?
Yes, that seems to be most of our patient mix at this time tends to be orthopedic or on their way to potential neurosurgical interventions.
In this magazine here, talking about pain management, it was talking about the difficulties in dealing with why doctors don't understand or why it's difficult to acquire this. And the third reason they mention is that your health insurance company don't cover some or all of your pain medications. Do you run into difficulty with health insurers in covering your procedures or approving your procedures?
Well, all of these procedures are elective, so they need to go through a pre-approval process. And there can be some resistance from that depending on the insurer, depending on the season, depending on the patient. And it's pretty hard for me to tell what the rhyme or reason is. I know when it comes to, expensive or more exotic or newer pain medications, they tend to be very much more resistant than if it were something typical like Lortab.
In your clinic, what else do you do other than nerve blocks? Do you have continuous pumps? Do you combine oral medication with nerve blocks or continuous infusion pumps? What are your guidelines, and how do you decide on the individual patient as far as what treatment modality you would recommend?
Well, obviously every patient's different, so we assess them individually, and usually by the time they've been referred to a pain doctor, the simple things, the non-steroidals have already been tried, and maybe low-level opioids have been tried. So once they've been referred to us, and we'll assess them, try to figure out what modalities might be useful to help with their pain, and just try to treat them individually that way, whether it be blocks, whether it be perhaps a consult to a neurosurgeon, whether it be continuous pain pumps. It just depends on what the patient's organic issue is.
I assume, knowing the difficulty in dealing with oral pain medication, most of the patients that you are referred have been on a multitude of different pain medications, from oxycodone, Dilaudid, methadone, fentanyl patches, and I would also assume that you don't just blatantly stop these abruptly because of the withdrawal effects. Am I right in saying, or correct me if I'm wrong, that in dealing with pain management and nerve blocks, that you gradually want to wean or reduce the amount of oral pain medication or even patches that the patient is on when you begin instituting nerve blocks?
You want to bring it down to a manageable level. I mean, obviously, when we're being referred pain patients from non-pain specialists, then, they're doing their best. They're doing good faith effort, and sometimes they just get, sometimes we get on, and the patients get on a concoction of medications that may or may not be something that a pain specialist would do. So what we'll try to do is, and again, individualize the treatment. Try to bring them. The goal, of course, is to make the patient as comfortable as possible. But part of the problem is explaining to them that you probably won't have zero pain, but we need to reduce it to a level where it's manageable, to where you're not, completely out of it all day because of the side effects from the oral medications. So it's kind of a fine balancing act in terms of maintaining, reasonable comfort with reasonable activity.
So I would be correct in saying a good many of your patients, even though they do have a nerve block or some procedure to manage their pain, still maintain some level of oral pain medication or fentanyl patch. Maybe it goes from 100 to 25 micrograms, but they still maintain some form of adjunct therapy along with your nerve block.
That would be correct.
Let's talk a little bit. I'm going to jump over to another topic. We're going to come back to the topic on pain management. Our guest today is Dr. Hubert Fu, F.U. He's with the Dallas Pain Clinic, trained at University of Texas Southwestern Medical Center in anesthesiology and pain management. The phone number at the Dallas Pain Clinic is 214-471-5975. Being an anesthesiologist, what are I run into a lot of patients that are chronic lungers, bad COPD patients, even oxygen-dependent patients. What are the criteria as an anesthesiologist in determining what patient can undergo, whether it be a CT-guided biopsy or a thoracic surgery CME procedure on a patient that is oxygen-dependent or is a chronic lunger, and you find that they have a mass in their lung and you need to get tissue biopsy?
That depends. You brought up a lot of interesting issues here. That'll depend on, what the CT surgeon thinks they're going to be doing, because quite often what they'll do is they'll assess the patient with pulmonary function tests, and from that he'll kind of decide how much lung he can safely take out without making the patient completely ventilator dependent. Obviously, we try to keep the patient as close to normal as possible. So the goal is to not to over-oxygenate them, not to keep them on a ventilator for extended periods of time post-operatively. But all of that just depends on the assessment of the anesthesia team and the cardiothoracic surgeon on what he thinks he's going to do.
In your experience, how much greater a risk factor is there in dealing with this type of patient who is undergoing either thoracic surgery or a interventional radiology procedure, a CT-guided procedure, of developing a pneumothorax? And to the audience, that's virtually a getting free air in the lung or a collapse of the lung after a procedure. How frequent is that in dealing with these type of patients? And if that occurs, how do you respond to this?
I wouldn't say it's obviously in this patient population, when you're dealing with a procedure around the lung, it's greater than, say, if you're dealing with an area that isn't around the lung. But in my experience, it's not a frequent thing. A few times it does happen, then at that point, a chest tube gets inserted to try to allow the lung time to heal and equalize the pressures.
Having said that, how much time is usually needed in preparing the patient to go through this procedure? Is it basically just getting a pulmonary evaluation? I know we recently had a patient and was turned down, had a mass that was growing. Fortunately, we were able to get the biopsy. There was a small pneumo, and they've responded very well to combination systemic chemotherapy and stereotactic radiation. How much time do you need in preparing a patient for a procedure like this?
You mean for a CT-guided biopsy?
Right.
Okay. It depends on it depends largely on just logistical coordination, because you're dealing with multiple teams of people here. If things can be done, if things are streamlined, it can probably be done in a matter of days. If it's an emergency, it can be done probably in a matter of hours. If it's just routine, it probably takes a few weeks to line all that stuff up.
Let's talk a bit about side effects of anesthesia.
Mm-hmm.
I know in my years in medicine, a lot of patients come out of anesthesia. They have elevated liver function studies that they did not have prior to that. I don't know if it's the drugs that were used prior to that. We also see, obviously, increased incidence of venous thrombotic episodes. Is there any correlation between anesthesia and venous thrombotic episodes, blood clots, deep vein thrombosis, or even pulmonary emboli with anesthesia? And going back to the first part of the question, what types of anesthesia are, quote, hazardous to the liver's health?
Well, okay, and that's a complicated question, so I'll take it in parts. The older anesthetic gases, like halothane, which is no longer in the market, could cause certain types of liver reactions. The consensus thinking on it now is that the modern anesthetic gases shouldn't do that. They don't tend to do that. But there's obviously the other issue you were asking about is venous thrombosis, and I think that can get conflated with the anesthetic protocols. But really, I think what we're trying to what you're asking me is there a correlation between surgery and venous emboli? And that's definitely it, because when you've got a patient that's laying still for hours on end, and they're set up for venous stasis and formation of clot, and from that for emboli from those clots. So there are protocols that every operating room has in place to try to cut down on those. We'll put devices known as sequential compression devices, which basically massage the legs to try to get the body to produce more tissue plasminogen activator to try to discourage the formation of clot. Post-operatively, most hospitals have protocols where they'll put the patients on some form of anticoagulant like heparin or 1 molecular weight heparin to try to diminish the incidence of those types of sequelae.
Let me talk about, I see patients in the hospital with venous thrombotic episodes, but let's take away from that. You do a lot of anesthesia work in orthopedics. Those patients that have knee replacements or total hip replacements or orthopedic procedures, are they automatically put on pain pumps? Number one. Number two, are they given, is it necessary for them to have a pain nerve block after their procedure? And if not, how many of them eventually need to have some type of pain management procedure after a total hip or total knee?
Well, in our practice, and I can't speak for everyone, in our practice of anesthesia with our orthopedic surgeons, we offer everybody some form of blockade, some form of nerve block. Sometimes, like for a hip, we'll offer a spinal block, which is good for 24 hours or so to take the edge off the pain. If it's a more localized procedure like a knee replacement, we'll offer them a femoral nerve block with a catheter, which just means we'll block the femoral nerve, leave a catheter in there so we can leave a pain ball there to keep bathing that nerve with local anesthetic and helping with pain control. Now, these types of procedures are nice, but they're certainly not absolutely necessary. And there's a certain percentage of patients that are so that just don't feel it's necessary and will refuse those types of blocks. And, they might take more pain medications on the floors, but compared to our blocked patients, but it's not, and they might linger a little bit longer in the hospital, but overall, it's not a life or death decision, that one.
All right, we're going to take a break here. This is Cancer Update, short walk through a long journey. We're talking to Dr. Hubert Fu. He will join us when we come back. Our number here is 972-445-0770. Please join us in about 2 minutes. Thank you.
Rosalind Slaughter is a very busy wife, mother, and teacher. She didn't have time for cancer.
After my first diagnosis, I had 2 lumpectomies, but the cancer had already spread. The doctor gave me little hope for recovery. That's when I called Texas Hematology Oncology for a second opinion. It had become stage 4 breast cancer.
The physicians and staff at Texas Hematology Oncology Centers aggressively attacked her cancer and were concerned about her quality of life during her treatment. Rosalind has been cancer-free for over 8 years now.
It really makes a difference who you choose for cancer treatment.
Rosalind and others have turned to the cancer treatment offered by Texas Hematology Oncology Centers. Perhaps you should too. Texas Hematology Oncology Centers has offices that are located in Dallas, Carrollton, and McKinney. To call for an appointment, please call 469-453-5500. That's 469-453-5500.
Good afternoon, everybody. We're back here at Cancer Update, a short walk through a long journey. The phone number here is 972-445-0770. The toll-free number is 877-272-5226. Joining me today from the Dallas Pain Clinic is Dr. Hubert Fu, F.U. He's a graduate of the University of Oklahoma Health Science Center, Methodist Medical Center in Dallas, and did his residency in anesthesiology and pain management at the University of Texas Southwestern Medical Center. I met Dr. Fu from his associate, Dr. Sanjay Isaac, and he is with the Dallas Pain Clinic. Their phone number is 214-471-5975. If you or a family member or a friend are looking to talk to somebody about pain management, I can tell you that this is an excellent clinic. They're very attentive. They take all insurances. Give them a call if you've got questions regarding pain management, whether you are a cancer patient or a non-cancer patient. Dr. Fu, let me ask you, in dealing with the cancer patient in the head and neck area that has resection and they go through a lot of pain from both the radiation and the surgery, what type of pain management have you seen other than oral pain management in dealing? Do nerve blocks play any place in the head and neck cancer patient for pain management? They can play some role in there, but usually what we try to do first is perhaps non-traditional oral meds like carbamazepine to try to dampen the nerve impulses that are causing those issues. But again, we try to individualize to what the patient's lesion is and to what their problem is. So it plays a role, but it depends on the patient to see how great a role it actually ends up playing. I have a recent patient, obviously I won't mention the name, that had a recurrent endocervical cancer, eventually decided to send the patient to a very proficient expert surgeon, did a pelvic exoneration, and the only problem we had with this, she has gone into remission, is pain. And it's the idea of conquering this, because this is what has made her quality of life miserable. She did better. She did well with radiation. She did well with chemotherapy. But after the pelvic exoneration, we've had a difficult problem in dealing with pain, and I plan on sending this patient over to y'all. Is there a place here for either a sympathetic or splanchnic nerve block or some type or form of nerve block? Because I know there are a lot of patients out there that go through some extensive abdominal surgery and are constantly in pain. Right. Most definitely there's a place for that. Obviously, we'd want to figure out where the pain is coming from, what the character for pain, how bad it is, if there is anything that causes it to vary. But if we narrow it down to one of the splanchnic nerves, then definitely, or those visceral nerves, definitely, that's something we'd like to go after. And first try, we'll do a temporizing block to see
if it actually helps them before going on to something more definitive.
Tell me, in your experience, what are the different types of pain management or pain control or procedures that you at the Dallas Pain Clinic will implement on the patient? I've only been talking here about nerve blocks. What else are you able to do that are beneficial to the patient who comes in with chronic pain?
Like I said, you can do pharmacotherapy, which is usually a nice conservative first step. Be it dealing with neuropathic types of pain. You can go on to nerve blocks like we were discussing. You can go on to nerve ablations if it's decided that the pain is isolated to that one area and it's worth ablating that nerve in a more permanent sense.
Nerve ablation, is that a injection or is that like a rhizotomy, a surgical procedure?
It's a pain procedure. It could be a rhizotomy. It could actually be just injecting a different chemical in there instead of what we would do for a more classical pain block.
Have you, in your experience for the audience, rhizotomy is basically cutting the nerve. Have you found in your experience that the nerve block has less complications than the rhizotomy?
Depends on the placement, and also depends on the proceduralist. I think in any case, as a general philosophical consideration, you want to make darn sure before you talk about getting rid of a nerve completely, you want to make darn sure that the benefit of that exceeds the risks and the costs of dealing with that. And again, that depends on the patient, the location, the extent of their pain. That's all those factors play into it.
Is most of your work done in pain management in orthopedics or in neurosurgery?
It's a mixture of both. Quite often they'll feed into each other because people that have back problems often have orthopedic problems and vice versa. So you'll find there's some commonalities between the patient populations.
I notice also that you do cardiovascular anesthesia, a lot of bypass surgery. My brother being one, he experienced a great deal of pain post-operatively, but he did not need to go have any nerve blocks. How many people that go through open chest surgery, be it lung surgery, but primarily CABG or coronary artery disease surgery, have a difficulty with pain management? And how do you recommend that this be handled in a medical point of view, or do they ever need to go to a pain management facility?
Well, I mean, it would be the rare patient that has chronic pain after that resulting from that procedure. Usually, from an anesthetic viewpoint, what you'd want to do, if you're concerned that the pain is going to be going to impede the patient's recovery, we would offer them, before surgery, thoracic epidural to try to cover. Like if you're contemplating taking out a lobe of the lung or something, what we'd do is we'd put an epidural needle higher than the level of where the surgeon is going to cut, and leave it in there, kind of like a labor epidural, but we'll leave it in there for 2 or 3 days while the patient's recovering, so that the worst parts of the pain and recovery are covered. Then we'll take it out at post-op day 3, and then usually they do quite fine after that.
Getting away from pain management and getting away from oncology, I'd like to ask you a question about duration of surgery and its complications. I would assume that age is a factor here. The older the patient, the more difficult the recovery time is if they're under anesthesia for a long period of time. Could you address the direct correlation between some major surgery and how long is appropriate, or how long should a patient, and what are the risk factors of leaving him under anesthesia for a long period of time? And I realize that's a broad topic. You've got to know whether or not they have lung disease, heart disease, what other parameters are there. But in general, what are the dangers, what are the complications for leaving a patient with a long duration under anesthesia?
Well, let's see. Long anesthetics automatically mean longer recovery times. If it's somebody who, for example, has had a back surgery for, we'll say, 12, 16 hours or whatever, there's a very good chance they're going to wake up with a lot more fluid that we've given them that they haven't been able to get rid of since they've been laying flat on their flat in a prone position, so on basically on their stomachs.
Did you say 12 to 16 hours they're under anesthesia?
Yes.
Wow.
That's not typical, but it does happen from time to time.
Okay.
I'm just citing a more extreme example. So
okay.
At this point, if they're like that, then you've got all sorts of fluid shifts, and this is where the art of medicine comes into play. It really depends on what the patient walked in with. If you've got a 19-year-old trauma patient, you can almost throw anything at them, and they're going to do just fine. If you've got older people, in your 80s, obviously they have less leeway to take that kind of hit. But you can have fluid shifts that impact the cardiopulmonary system. For somebody in an extreme case like that was on there a long time, you might not even bother extubating them at that time. Let them go to the ICU and slowly come out of it there. It just depends on the duration of surgery and how sick they were before, and your comfort level with letting them try extubation, especially if it's late at night or in the middle of the night. That might not be the most prudent action you can take.
I basically assume the older the patient, the increase in the comorbidities, the longer the recovery time and the longer the risk, the higher the risk factors. You would agree with that?
I would.
Okay. In your experience in dealing, let's go back to pain management. I just came across a question that was bothering me. In dealing with pain management, one of the cases I have right now is a young man that has a desmoplastic round cell sarcoma that basically we've stopped all types of therapy, a very young man, and his quality of life is dramatically compromised because of the amount of pain medication he's on, and we're contemplating sending him over either to you or Dr. Isaac to see about doing some type of nerve block on him. His pain is mostly in the lumbar pelvic region. In your experience with sarcomatous patients, and even in the metastatic area, is it difficult to achieve good control of pain, either in isolated sarcomatous disease or metastatic disease?
The more isolated lesion is, or the more focal a disease is, the easier it will be to deal with. Obviously, if it's spread across multiple nerve distributions, then it just becomes vastly more difficult to achieve a perfect result for these patients.
To the audience, we're talking with Dr. Hubert Fu of the Dallas Pain Clinic. The phone number there is 214-471-5975. If you'd like to call in and ask any question of Dr. Fu, we'll go on a little bit further here. In dealing with pain management, how often? Like I had, because of a collapsed vertebrae, I had an injection, did not take initially, came back about 6 weeks later. The second injection lasted about 18 to 20 months. In your experience, how often to reach good quality of life, be it, well, we'll ask it in two ways, be it a cancer patient versus a non-cancer patient, do they have to come back? Is it usually a one-shot time? And if not, how many times do they have to come back? And number two, is it different between a cancer patient and a non-cancer patient of reaching that threshold of pain relief and pain control?
Okay, interesting and complicated question. Let me deal with the easier part first. Typically, there are a lot of trial of 3 injections to see if things are going to take or not. And the general thing is if you don't have it after 3 shots, no pain relief, then that's probably not going to be a modality that helps these patients. Now, in terms of how well a cancer versus a more typical pain patient does, again, it very much depends on the patient, him or herself. to see how they do. My gestalt is that the cancer patients, it's a little easier to isolate, the causes, but that doesn't mean that it's easier to deal with the causes.
Okay. Why have I been told that you can only have so many injections at certain sites? Do you get calcification, sclerosing? You damage the tissue, or what is the limiting factor in getting repeated injections?
Quite a bit of it is what the insurance companies will tolerate.
Really? Mm-hmm. It's not any type of medical or physical problems that arise. It's the insurance company.
Well, that's part of it. The other thing too is, if you've failed two or three trials, and the thinking is then, if you haven't had relief after 2 or 3, why expose them to the dangers of the fourth one when you're pretty darn sure that it's not going to work?
If you have somebody that you give one and your second one takes, mm-hmm. and they've responded very well for 6 to 9 months, and then the pain comes back, are they a candidate for going back in and doing another injection? And do you inject? Is it safe to inject the same area?
Most definitely, yes.
And in your experience, the insurance companies will pay for this,
right? That part's not an issue. What they want to do is they want to reduce the number of people that are just doing procedures without any benefit. But if a patient is receiving a benefit from it, i.e., less pain, then that means, from a third-party payer perspective, that they'd rather pay for an injection once every 6 to 18 months than going for a full-blown neurosurgical procedure, because that just makes economic sense.
We're coming near the end of the program. I do want to ask you one question, and I really appreciate you joining me today, Dr. Fu. How many of the patients that you see for pain management, be it a cancer patient or a non-cancer patient, are basically addicted to their pain management, and how difficult is it to get them out of that addiction with a successful pain management injection?
Well, this is the thing that scares everybody. Scares non-pain practitioners because I think the statistics I read said that last year more people died off of overdosing from legal prescription medications than off of illegal drugs. So the issue is definitely out there, and everybody's watching to see how physicians deal with these sorts of things. One of the things that pain practitioners tend to do is when they accept a new pain patient, they sign a contract with a pain contract with the patient, saying that they're only going to get their pain prescriptions from me, the pain doctor, not anyone else. They're not going to go pharmacy hopping. They're not going to go to all these ERs and try to get their fix. And a lot of practitioners will also attach a consent for random drug testing to that too. And if they fail these drug tests, then the therapeutic contract is over.
And you will dismiss them from your care?
Correct.
Okay. And there's no fear of repercussions legally to you or your clinic in doing that?
They signed a contract.
Okay. All right. Dr. Fu, I want to thank you very much for joining us today. This is Dr. Hubert Fu. He is with the Dallas Pain Clinic, 214-471-5975. I know his associate, Dr. Sanjay Isaac, very well. It has been an absolute pleasure having you today. I hope the audience will give you a call because I think you offer a great deal of quality of life and relief for patients, both cancer and non-cancer. We're going to take a break here for a moment, and we'll come back to finish up our program. Dr. Fu, thank you for joining me today.
Thank you for having me.
Rosalind Slaughter is a very busy wife, mother, and teacher. She didn't have time for cancer.
After my first diagnosis, I had 2 lumpectomies, but the cancer had already spread. The doctor gave me little hope for recovery. That's when I called Texas Hematology Oncology for a second opinion. It had become stage 4 breast cancer.
The physicians and staff at Texas Hematology Oncology Centers aggressively attacked her cancer and were concerned about her quality of life during her treatment. Rosalind has been cancer-free for over 8 years now.
It really makes a difference who you choose for cancer treatment.
Rosalind and others have turned to the cancer treatment offered by Texas Hematology Oncology Centers. Perhaps you should too. Texas Hematology Oncology Centers has offices that are located in Dallas, Carrollton, and McKinney. To call for an appointment, please call 469-453-5500. That's 469-453-5500.
Good afternoon, everybody. These are the closing moments of Cancer Update, a short walk through a long journey. I want to thank Dr. Hubert Few of the Dallas Pain Clinic. Their phone number is 214-471-5975. If you need any other phone numbers or information, call here at KAAM at 972-445-0770. Again, our guest last week was Hospice Plus. Their number is 214-343-7900. In dealing with pain management, one of the problems that we have come into is that too many of us have adopted a, quote, pop a pill mentality. You need to explore all your options, then work together with your healthcare provider, doing your part to help yourself. Patients really need to be participants in their pain management, be open-minded and willing to try different approaches, even injections or acupuncture, until you find the ones that work for you. Some of the most effective and safe non-drug options for many pain conditions include physical therapy, massage, hot and cold compresses, stretching, yoga, biofeedback, and stress management. Keep in mind also that your drug regimen may need to be tweaked and modified over time if what you're taking doesn't work. Talk to your doctor. Consider nerve blocks. I have found in the many years that I have been dealing with cancer pain management that nerve blocks are absolutely necessary. A patient of ours named Mrs. Pitcher broke her back in an accident. She was a hematology patient. She was reluctant to go on long-term morphine because she had a fear of becoming an addict, of taking a narcotic. Her husband and her family were concerned about her using a powerful and stigmatizing drug. But after trying various therapies that did not work, including acupuncture, she agreed to take the opiates. She eventually went and had a nerve block that reduced her use of the opiates by over 75%. So in my question to Dr. Fu earlier, many of the patients still maintain the use of oral medication, but the degree of using it is reduced. I have found over the years that the use of narcotics and opiates in particular will reduce respiratory function, and we are very cautious in giving them to cardiopulmonary patients, increasing their shortness of breath, reducing their vital capacity for breathing, causing even some syncopal or passing out episodes. It also depresses your appetite and causes you to go through a depression by taking these opiates. So we are very careful in watching the use of these drugs in order to maintain a good quality of life. The end result here is to try and get the patient back to as normal a functioning condition as possible. The last thing is, you think suffering is normal or something you need to power through. As a chronic pain patient, you're already facing sizable challenges. Because you're your own best advocate, keep searching until you find the right doctor for you. Keep an open mind and look to the future. Above all, stop believing that suffering is just a part of life. While most chronic pain suffering won't experience 100% relief, the great majority should be able to see enough improvement that they can regain function and enjoy a better quality of life. Patients should not accept that they have to live with pain that's disabling. Take the advice that we've tried to give you today. Even acupuncture can be effective. I've had friends that have gone through acupuncture who've had hip surgery and knee surgery that has been very effective. Massage therapy has been excellent in back pain post spinal surgery. But again, for me personally, I can attest to this myself. It was a nerve block that eventually got rid of all the pain I had in my lower back and in my hips and legs. And I have seen remarkable results in dealing with somebody like Dr. Fu in the Dallas Pain Clinic, in dealing with abdominal pain post-surgical, and in pain management for cancer patients. This is Cancer Update, a short walk through a long journey. Please join us next weekend. We hope to bring in here a radiation oncologist to talk about all the new aspects of radiation therapy, both conventional radiation, CyberKnife, Gamma Knife, and IMRT and IGRT. So give us a call here at KAAM at 972-445-0770. This is Dr. Berenbaum signing off. Have a lovely weekend. Go Ponies, go Cowboys. Bye-bye.
You've been listening to Ask the Pros, heard every Monday to Friday right here on 770 KAAM. Should you wish to speak with any of our experts, please call KAAM at 972-445-1700 and we will connect you with them immediately. Thank you for listening to Ask the Pros.
The views expressed in the preceding program were those of the speakers and not necessarily those of KAAM, DJRD Broadcasting, or its sponsors.